Yes, welcome everybody. My name's Robert McCartney. I'm an associate here at Hempsons in the primary care team, with a particular focus on kind of the corporate commercial work. I'm joined today by Sam Wright, who's an associate in our healthcare advisory team, who I'll leave Sam to introduce himself in a moment. But before I do so, I'd just like to say the quick introductions to Hempsons for those of you who aren't may not be as familiar. We are primarily a healthcare team. We cover 5 offices across the country in Southampton, London, Harrogate, Manchester and Newcastle, and we provide a very wide range of legal support services that we can address most legal points for you in the context of the NHS and healthcare more generally. I'm really pleased to be joined by Sam today, as this is an opportunity to engage with our healthcare advisory team on this relatively new topic, or it's certainly evolving topic, as part of our monthly series on primary care issues and primary care topics that we try to address. For those of you who are unfamiliar with why we're having a discussion at this point, in Amanda Doyle's letter that addressed the contract changes for the GMS and PMS agreements published earlier in the year, there was a relatively short paragraph that referenced the having regard to the primary care patient safety strategy, which was published back in September last year. For something that was a very small paragraph in a fairly large document that had a lot of issues that needed to be addressed, that one comment actually has quite a big impact on how practices will be expected to manage their incidents going forward. And that's why I thought it'd be useful to invite Sam to introduce this topic to us today. I'm aware that there are practices who are piloting this strategy across the country, and some of them may or may not be on this call. So if any of you are involved in and have active experience in this, feel free, particularly at the end of the session, to let us know and tell us how your experience has been, but of course no obligation to do so. Right, on that I will hand over to Sam.
Thank you, Rob. Good afternoon, everybody. Thank you for joining us. So my name's Sam Wright, and I'm one of the associate solicitors in the healthcare advisory team at Hempsons in Manchester. I deal with predominantly inquests, the representation of NHS trusts at inquests, and also at some advisory work. So as Rob said, we thought that it would be a really good session to introduce the primary care patient safety strategy and just open up a webinar to discuss that with you. My background in terms of patient safety, I work with a lot of secondary care clients, NHS trusts, hospitals that currently and have been observing PSIRF, the patient safety incident response framework, since 2022. So it's an opportunity for me, of course, to bring that experience into this webinar today and tell you a little bit about what might the expectations be for the primary care sector. And I'll also give you the opportunity to ask questions in and around what that looks like as well in secondary care, and I can try my best to answer those questions for you too. You'll notice that we have put part 1 as it's intended, that today, for the purposes of today's session, we'll talk about the patient safety strategy in primary care, and then we'll look to deliver a more detailed webinar just centering on and focusing on the patient safety incident response framework, which otherwise known as PSIRF, for you at a later date. PSIRF is a session in itself. It's probably more than one session in itself because it's quite big. But for the purposes of today, we'll talk about the strategy itself, what that entails and what the expectations are for the primary care sector. So moving on then, we will have a look at, for the purposes of today's session, what is the primary care patient safety strategy? You've probably already guessed that we're going to be talking about that by now. Who does it apply to? Why has it been introduced? What are the main objectives? What are the local expectations? What can you do as a practice to prepare or start to prepare? We'll then introduce PSERF. We'll provide a summary in and around PSERF, but we won't be going into it in a whole lot of detail for the purposes of today. We'll then talk in and around any assistance that might be available to you, and then of course we'll open up questions further down the line. Okay, so what is the primary care patient safety strategy then? It outlines the local and national commitments to improve patient safety in primary care. So for the purposes of what you'll be interested in today is, of course, what those local commitments are. There will be national commitments, and the idea is the national commitments will be rolled out, and then what will be fed down as to what then the local commitments will look like. We'll look at some of those local commitments for the purposes of today and discuss what that might look like for your practice. And there will be a focus on learning from patient safety incidents. Well, that goes without saying, doesn't it? Because of course it's the patient safety strategy. It promotes the modernisation of incident reporting systems. Implementing patient safety training. There'll be an emphasis building a safer culture, a just culture, and it is designed to be adaptable and flexible. So we'll just have a little talking in around some of those points just to expand on them a little bit. So implementing patient safety training, there'll be a lot of training and being implemented as part of the strategy, training and primary care for providers in terms of what patient safety analysis should look like, recording of incidents, the expectations in and around that, and then further to that, investigations and how a practice might conduct an investigation, and of course observing PSERF. There'll be an emphasis on building a safer culture, a just culture. Now you might have heard this phrase, a just culture, being bandied around quite a lot in this context, certainly around any discussions or any forums discussing PSERF itself. Now, just culture is a focus on where errors are seen as opportunities for learning and not just blaming individuals. It's a fair and supportive environment for staff, and it's an opportunity to critically review and act upon any investigations, and of course following on from that, learning from any incident that's taken place, and really looking forward on how we can try and prevent any incidents from taking place and further down the line. The strategy itself is designed to be adaptable and flexible, and what that means is it's recognised that the primary care sector is different in the way it's set up. There's we have large practices, we have smaller practices, and sometimes the resources just aren't available in terms of huge governance teams being built up in a particular practice itself. So it's designed to be adaptable and flexible in the sense that you can only work with what you've got. So the expectation is learning from incidents and having a patient safety plan in place as time moves on. But of course, it's got to be reasonable and in terms of fitting your particular practice itself. For instance, in the secondary care sector, we've got whole governance teams that work on patient safety incidents themselves. It might be in one primary care practice, you just have one individual, you have one governance manager, one risk manager that's overseeing everything, and of course everybody has a responsibility in terms of patient safety, and we can discuss that as we move forward. So the adaptable and flexible nature of the strategy itself is because it's recognised that the primary care sector might not always have the resources to put together huge teams to put in place patient safety plans. And having said that, it doesn't mean that it can't be done. It's just going to have to be done on a smaller scale. Okay. So who does it apply to? I don't know why I put that, because of course it applies to the primary care sector. But the reason why I wanted to just highlight in the initial circumstances in relation to this is because it applies to the primary care sector, but there's a huge focus at the minute on general practice in the first instance. And what that will do is general practice will start to roll out and observe the strategy, and hopefully further down the line start to implement PSERF. And other primary care sectors, other primary care organisations then can adhere and learn from any successes that the general practice sectors have had, and then learn from their experiences as they go along. So as an initial stance, it's for general practice to start to observe and roll out the strategy. Okay, so why has it been introduced? There are between 20,000 and 30,000 incidents of significant avoidable harm reported in general practice each year. Now that seems like quite a significant number, and of course it's a significant number in the sense that we don't want any patient safety incidents or any significant avoidable harm reported. I think getting to that position is unlikely, but if we can reduce the amount of significant avoidable harm, then of course that's only a positive. And I just want to add to that section that 97% of GP interactions are all positive interactions with no harm established at all. So that gives you an idea of course the size in terms of the numbers. So we're still talking quite small numbers, but of course that high in the context of things. The total cost to the NHS is in around £1 million per year. The top three incidents are misdiagnosis, medication related, and delayed referrals. And the main objective, of course, of the strategy is by building safer cultures and systems, and therefore reducing the incidence of avoidable harm. Okay, so how do we move on to do that then? So the main objectives of the strategy itself is to improve communication between the different areas of primary care, introducing a new national care record service that promotes a culture of safety event recording in primary care, together with an improved learning response, improved information systems, improved communication with patients, addressing any barriers to digital health for some cohorts of patients, and introducing a new learn from patient safety event service. Now, you might have heard of the Learn from Patient Safety Event Service. This replaces the national the NLRS, which is the National Learning Reporting Service. And I think actually LFPSE now is in full swing. Okay, we've already talked about the culture of safety event recording in primary care. It's well recognised that patient safety recording in primary care is underdeveloped when compared to the secondary care sector, and because of that there's a concern, of course, that we're missing out, that the primary care sector is missing out on not fully being wholly aware of patient safety incidents and what those incidents look like. What the LFPSE looks to do, which is the Learn from Patient Safety Event Service, is a national recording system, which of course primary care sector the primary care sector will have access to, and the idea is to observe, record incidents, and of course record the incidents on the system itself. It's a national system, so of course when you record your incidents, it provides you with a dashboard of your incidents, and moving on from there, it's a case of collecting that data, establishing what the themes are, and then working out whether there's any learning or any improvements to be made as a result of that.
Could I just interrupt there for one moment? I just want to, just because this is a question that came up in a previous webinar, in which we discussed this with some other colleagues. And one of the concerns that we've seen, and I've certainly heard, is a concern that this will be used in some way against practices. So almost you report them all nationally, and then you'll get a report of who does it well and who does it badly. Now, that's not the intention of this. It is an opportunity to share data and to develop shared learning. And it's that idea of having over 6,000 practices in the country, being able to take single lessons from that, though individually, is really difficult. Having a collated view across 6,000 practices, though, can help with learning for everybody. But I do kind of understand that there is a fear it might somehow be used against the practice. That certainly isn't the intention, as far as I'm aware.
No, absolutely not. And it certainly comes back to the just culture and making sure that, you know, where there's learning opportunities, practices are learning from any incidents that do take place. It's not a focus of blaming any particular individual or practice. And of course, what we have to realize is without that collection of data, not just for one particular practice, but a number of practices as well across a broad range, it's when you really get a full feel of what the issues are. Because in a sense, if one practice is having a particular issue or there's a theme in one practice, it might be that similar theme is occurring in a different practice. And when you collate all that information together, that's when you have a real clear and bigger picture in terms of what steps then need to be taken, whether that's at a local level or a national level, to increase patient safety in that respect. And that's exactly what it's for. It's a confidential database. It's not a database where any one local practice, as far as I'm aware, will have a published report on what it is that what their incidents are. Their incidents will be specific to that particular practice. They'll have their own dashboard, from what I understand, and they can then utilize that to put changes and assess the learning and put things in place where it needs to be in place, to ensure patient safety where changes need to be made. In terms of the local expectations, then, locally, there will be an expectation for the development of mechanisms which support the adoption of the Learn from Patient Safety Events system, and of course PSAFE in primary care. Another expectation will be to register an administrator account with the LFPSE or connect your current system. In terms of connecting your current system, I understand if you've got a local risk management system that's compatible with the Learn from Patient Safety Event system, there's a way of connecting the two. If you don't have a local risk management system, then of course you can register an account with the LFPSE, specifically with your NHS email address and your practice email address, and you can access it that way and record any incidents that way. When we're talking about recording incidents, this isn't a system where you just record incidents where harm has occurred. Even if it's an incident and luckily nobody's been harmed as a result of it, that's still a recordable incident, because if it could have led to harm, then of course there's some data there that needs to be captured to evaluate whether any further learning needs to be put in place in the future. Primary care providers to encourage individual practitioners to register with the LFPSE as well, and of course general practitioners to start the implementation of PSAFE. Now, PSAFE, we did say we'll talk about that a little bit later in another webinar in further detail, but with the Patient Safety Incident Response Framework, it's a part of the whole primary care strategy, but it's not the main the main part. It will be as time goes on, but the way I see things currently is that there's, depending on where your practice is with patient safety, it will depend on whether your practice is now ready to start to implement PSERV. PSERV comes once we've started to make meaningful progress on recording incidents. But before we can start meaningful progress on recording incidents, we also need to make sure everybody within that practice is fully on board, understands what it's for, and that goes hand in hand with some initial training as well for staff, and for staff to understand that patient safety is everybody's responsibility. It's not just the GP partner's responsibility, it's the GP partner's responsibility. It's everybody within the practice, no matter what your role, everybody's responsibility for patient safety, and therefore to be recording incidents as you go along, and if the requirement permits. So we talked a little bit about the Learn from Patient Safety Events system, and we thought it might be helpful to talk a little bit about what that is and what that does. So it's a national NHS service for the recording of patient safety events. You've probably already gathered that by now. It replaces the National Reporting and Learning System, which is the old system, and this incorporates a single national NHS system. It's anticipated that this system will continue to grow and evolve with user feedback. So it's not currently in its final form. It's anticipated that as users start to use it and more practices come on board with it and start to play around with it, input data, it's expected then that individual practices will then provide feedback on the system, and provide comments on where it works really well, how it could work better for them, and then more add-ons will be added, more fields will be added to the system as things move on, and as the primary care sector progresses with the patient safety incident recording and learning.
Again, just on that point, I think many practices out there have had, shall we say, challenges with systems, and I'm particularly thinking about CQC and when they introduced their new system a year or two ago now. Am I right in thinking that this system is already established, though? It does exist in a format and is being used by trusts. It's still in its early days for primary care. Is that correct, or have I misunderstood that?
Yes, it is already a system, and it's already a system that you can log on to and use. In terms of whether there's been any teething issues or any comments or feedback in terms of how that works, I guess for individual practices, it'll be a case of just getting on there and seeing how it works for them. And of course, if they've got any queries, you could go back to the provider. There'll be a support service as well as part of the LFPSE if there's anything that any information or any direction that they need on in terms of what they need to do with certain fields. But it is very much a system that is in place now, and you can log on to it. You could create an account today. I've had it. There'll be a link actually on the end of the slides in terms of where you can access it. I haven't accessed it myself because, of course, I don't have an NHS email address, and I think you need one to be able to do that. So I'm unable to say what it actually looks like when you actually get in there. But yeah, there will be a support service, I'm sure, as part of that for any questions to be answered. Or any queries. Okay, and here we are, registering the LFPSE system. So there's just a little bit of information on that and how you might do that. And we mentioned before, didn't we, that if you already have a local risk management system, you can link it to your local risk management system, and your local risk management system provider should be aware of the LFPSE. So it would be a case of, I expect, calling up your local risk management provider and having a chat with them about how they link their current system, or whether that's something that can be done for them. If you don't have a local risk management system, then it's a link through the Connect NHS applications account to log on to that. If you do a quick Google search, LFPSE incident recording, it'll take you straight to set up an account, and you can go through it that way.
One example of a system that I know is connected, just to give an example, is GP TeamNet. That type of large-scale system already has the functionality. It's just a question of you need to engage with them to actually switch it on and to let them know that you're getting dealing with. So certainly the large providers of these systems are able to help you. If you are using just a local system, as in Excel spreadsheets and records yourself, then you will need to spend a bit more time to log on and get used to how reports need to be made.
Yeah, absolutely. And I think, like with any system, anything that's new, it'll be very much a case of creating an account, having a look at it, having a look at the various different fields in there. What information does it require? And actually, it'd be quite helpful, because if it will inform you to a certain extent as the types of information that you're looking to input and the information that you need to gather once an incident is flagged up within your practice. So that is a lot of information for everybody, and I guess I expect and I anticipate that the practices on the call today, everybody will be at different stages as to where you are within your practice with patient safety, how incidents are recorded, and what you do with that information thereafter. We know that there are some practices out there that's already started to roll out PSERF and observe PSERF as well, and some practices are further forward than others, sometimes the larger practices possibly. And some might not have even started or considered a way forward in terms of the strategy itself. So we've just put together a few things here in terms of what you might be looking to do to prepare in terms of the local expectations within the strategy. So one of the things is identify patient safety leads within your practice. So who's going to lead on patient safety? Who is it that we need to be making aware that an incident has occurred? Who is it that needs to obtain that information, and what do they do with that information thereafter? Identify 2 or more patient safety partners, again, that would work hand in hand with your patient safety leads. This is just suggestion, by the way. It might be that you don't even have the resources for 2 patient safety partners, and then 1 or 2 patient safety leads. It really does depend on the size of your practice and what's doable in terms of the resources that you have. Consider how continuity of care might be provided moving forward. So continuity of care is one of the things that the strategy expects where possible, and I think that's down to the fact that, of course, if you're a GP and of course you're seeing the same person time and time again, you develop some really good relationship, good knowledge of that particular patient, what their challenges are, what their health is, what the next steps. And sometimes where we don't have continuity of care, that's where we've seen gaps in terms of where things might go wrong in terms of incidents, because of course you're relying on then the patient record, you're relying on having the time to read back in the patient record to see what the current position is with that particular patient. Of course, a 10-minute GP appointment, who has the time to have a huge look back at the notes. So register for the LFPSE system and add incident details to that system, and then further down the line observe PSERF and identify what this looks like for your practice, and then again further down the line start to implement PSERF. Now, before all that can be done, it is recognised that there does need to be a shift in the way people feel about incidents and the anxieties around not wanting to report incidents because of the fear of being blamed for a particular event. And that is completely understood. But as soon as we start to train staff and provide case studies to staff about what this is about and what the ethos of the patient safety strategy is, getting people on board, changing their view, you know, more and more, if we educate people, they'll be able, you know, you'll find it easier to be able to get everybody on board in terms of change. Change is hard, no matter what it is that you're trying to do. But in this context, it can be equal, you know, even more challenging because, of course, we're stuck in a system where people are concerned that, well, if I report that or if I raise that, then someone else is going to get in trouble, or I'm going to get my colleague into trouble. It's not about getting into trouble and blame. It's about systems-based approach in terms of looking at incidents and looking at what has gone wrong. It's a system that has failed generally when something goes wrong, and it's looking at that system and seeing how that can be changed moving forward to learn from events and to minimize the risk of those events from occurring again moving forward. Okay, so I did promise you we would talk a little bit about PSURF because, of course, it's such a huge part of the strategy. It's not the only part, but it will form a huge part of the strategy itself. So once a practice is in a position where we've started to, you know, change mindsets in terms of recording incidents. Incidents are being recorded and investigated adequately. Then we start to look at implementing the patient safety incident response framework, which is a framework which should focus on learning from incidents to improve patient safety. And the emphasis is on how incidents happen and using a systems-based approach to identify root causes. It prioritizes engaging with families and staff affected by incidents and ensuring that they have a voice in the investigation. So the families and patients are very much at the heart of any patient safety incident and any investigation that follows from that, and that gives them a voice in terms of helping form how learning occurs moving forward and what's obviously important to them. It's a systems-based approach rather than focusing on the blame of individuals. So just like we've said, it's about analysing the system itself and thinking, right, what went wrong here? Where is the gap in the system? How can the system be changed to ensure that this error or incident doesn't occur again? And PSURF obviously provides and promotes oversight to enhance learning and improvement within an organisation. So what that means is there's a requirement within PSURF that we have, you know, we don't only look at the incident itself and look at how it might be prevented. We also look at where the learning is, and of course how exactly that, how it might be prevented moving forward. And of course, what goes hand in hand with that is continually to audit that the processes that we've said we'll put in place are in place and that they're working, because of course we could have an incident, we could draw up some actions, we could say what we need to do, we could put them in place, but we need to make sure then that there's follow-up to make sure that they're continually in place and that they continue to work. So that's a little bit on PSURF itself and what the expectation is in and around that. There's a whole host of information on PSURF that we're able to provide, and of course we will deliver a part 2 session to this particular session to talk a little bit more on PSURF at a later date. So how might we help individual practices with the implementation of the strategy itself and, of course, PSURF moving forward? We can offer bespoke PSURF policy drafting services, bespoke incident recording documentation tailored to your practice, bespoke incident recording investigation standard operating procedures tailored to your practice. So what that is an operating procedure in terms of how incidents are going to be recorded. What we do then with those incidents, a step-by-step policy on how that process works and what it looks like and the steps that need to be taken and the responsibilities of various individuals in that process itself. We can offer incident investigation services and, of course, on-site and in-person training on the implementation of PSURF when you get there. And I think that brings us to any questions. So thank you very much for listening.
Thank you very much for that, Sam. And we've got a couple of questions. I've been addressing some of them in the chat, but we'll just go through them for those of you who want to hear the answers. I won't mention names just in case you'd prefer us not to. So the first query was about, has the Being Fair tool not superseded the Just Culture guide, or are they both in alignment? Now, I'm happy to answer this one. There's this is a terminology issue, really. Yes, you are correct. Being Fair tool has replaced Just Culture guide. But what that is about is specifically incidents and investigations relating to kind of performance management and individual issues that directly relate to kind of individual performers, as opposed to the general, conduct of fitness, that fitness of practice, that kind of stuff, as opposed to the more general conceptual issue of a just culture, which the strategy is trying to achieve. So there's a slight overlap of terminology, which does occur on these occasions, that may not be helpful, but just think of them as completely, as one is a toolkit for specific issues, the other one is more conceptual. So hopefully that helps. This one you might be able to provide a bit more information on, Sam. We were asked, do CQC have access to the information? My understanding is that they do. They haven't, but this is the same access as they used to have under the old system. I'm not sure the extent to which they will review it and if it's flagged with them. But I don't know if that's anything that's been addressed with your clients, maybe in trust kind of perspective, historically.
Yeah, I expect if they've had access to the previous system, then there's no reason why they wouldn't have access to this system. In terms of how far and what they do with the information, or whether anything's flagged up to them in relation to anything, I'm not quite sure. But what I could do is I could find out a little bit more information in and around that and provide a written response if that would be helpful.
Great. Yeah, we'll look into that one in a bit more detail. Thank you. So we also asked, it's a setup question about how do you set up a practice, set up an account for practice for an individual at the practice, and then someone else has helpfully provided a bit more of an operational response. I can give you the general response, is that it's linked to your organizational code, your ODS code, the same code that you would use for, say, your data protection toolkit type submissions. Well, that's a bit of an old terminology, and now I know, appreciate. Often it's also your contract number, the number linked to your GMS contract or your PMS agreement. In terms of, there was another response from somebody who's actually dealt with, said individuals might have admin logins. We'll leave that over to you from a practical perspective. I'm pretty certain there's some good guides on their website about exactly which applications needed and what support is required on the LFPSC website. There's a question here about the patient safety strategy focuses on the learning, not on finding root causes, which previously apportioned blame. It's an interesting to get your take on that one, Sam. I'm certainly, when I've done root cause analysis investigations into incidents in the past, blame was never the intention. It may have been a consequence. I mean, it is a tool after all that needs to be used. And you do need to find your root causes, even when to be able to get the learning. But it's an interesting take on how do you think that evolution into a more of a learning kind of culture might impact here?
Yeah, it's very much a shift in the way people think about incidents, really. Naturally, when something goes wrong, it's human nature, isn't it, to think, right, well, who's responsible for this? And it's about moving away from that whole thinking, really, in terms of thinking, well, actually, what's the system in place? What system was being operated when this thing went wrong, and where did that system fail? So it might be, say, for instance, try and think of an example. It might be that there's been a referral letter for follow-up for someone on a cancer pathway, if you like, and that referral letter hasn't been sent out for whatever reason. Now, instead of looking at, well, who was it responsible for sending that letter out and who didn't do it because they're at fault, it's more of thinking, well, actually, why was that letter not sent out? Looking behind the actual person and actually looking at the system and thinking, was there a glitch in the system? Was there a system error? Did something not flag up for that particular person to give them a key task to say, get that referral out to Mrs. X, or once the referral was sent through, what was the reasons why it didn't come through? Why didn't they see it? So it's about looking at what systems are in place. So there's nobody, the whole ethos is, it's appreciated that there's nobody working in the NHS, wide, that wants to not do a good job. Everybody's there to do a good job, and there's a reason why things go wrong, and it's about looking at that system and where that failure in the system has occurred to put those things right, rather than looking at one single individual. Yes, individuals will be involved, and it might even be that there's individual learning for those members of staff in that process, but then you look to, well, okay, well, that's a training issue. So you're back to the system. Have we trained that member of staff? Do they need reminding? And if they do need reminding, let's remind them of what needs to happen next time. And actually, while we're at it, let's remind everybody else so they're aware of it as well. Does that help?
I think it does. And there's another comment just come up here, said, I'm not sure how you can foolproof against human error. And I agree, errors do happen, issues happen. And one of the kind of key shifts of this mindset, and I know the trusts have been going through this as this has been evolved over recent years, but even when I was in-house in a trust, or over 10 years or 15 years ago now, oh God, getting old, we were trying to make this this shift, but it was in a different culture, and that's away necessarily from the concepts of serious incidents and significant events and that terminology, to where the new structure is more about identifying that incidents can be of any kind. They could be at different varying degrees, but they're worth investigating and worth doing a bit of work on, and putting as many protections and safety barriers in place as you can, which, granted, may not foolproof against human error, but it does reduce the risk, and it will identify opportunities where you can put in additional protections where possible. Unless anybody has any other questions, I feel that we're probably at the end of our discussion. We will be, as I say, as indicated earlier, we'll be sharing out a recording of this webinar. And we will also be following it up with a podcast in due course for a shorter kind of snappy kind of oversight of this. Later in the year, we'll be looking into the PSRIF in greater detail, doing a bit of a deeper dive into what it practically means for the practices, and how general practice can embed it. And it'd be useful if anybody wants to reach out and make contact, if you have worked through the pilot program on either the first one or the current one, it'd be great to have a chat with you and see if we get some practical examples ready for everybody. In the meantime, if anybody has any queries or wishes to get some additional support on any of this, please let us know. So Sam and I's details are available here. I hope this has been useful for you all, and look forward to engaging with you further in the future. Thank you.
Thank you.